Welcome to the Deep Dive. Today, we're getting into a really common reason people end up in A&E with tummy pain, acute cholecystitis.
That's right. Basically, a suddenly inflamed gallbladder, usually because something's blocked the exit.
And we're digging into our acute cholecystitis revision notes for this one.
Yep, the plan is to pull out all the essential bits you need to know, make it clear, make it stick, without, drowning in detail.
Sounds good. So let's start right there. What exactly is acute cholecystitis? Define it for us.
Okay, simply put, it's inflammation of the gallbladder. And the main cause, like over 90% of the time.
Gallstones.
Gallstones. A gallstone gets lodged in the cystic duct. That tube draining the gallbladder bile backs up, pressure builds, inflammation starts.
And that causes the pain.
Exactly. Sudden, pretty nasty pain in the upper right side of the abdomen, the RUQ. And often systemic stuff too, like a fever.
Okay, so mostly gallstones, but you said mostly. Are there other less common causes?
Yeah, much less common, but you can see it with gallbladder sludge, just really thick bile. Or sometimes ischemia, where the gallbladder doesn't get enough blood.
Ischemia, right?
And very rarely maybe a tumor involved, but gallstones are definitely the headliner.
Got it. And these gallstones, they're not all the same, are they?
No, not at all. There's quite a variety. The most common ones, certainly here in the UK, are cholesterol stones, about 80%.
And what are they like?
Generally bigger, maybe just one, and crucially, they're radiolucent.
Meaning?
They don't show up on a normal x-ray. You
Wow.
need ultrasound.
Okay.
You've got black pigment stones,
Mhm.
smaller, bit more crumbly, also radiolucent, often linked to things like haemolysis or liver cirrhosis.
Right.
There are mixed stones too, a bit of cholesterol, bit of calcium, bit of pigment, often faceted, sort of worn smooth from rubbing together.
Mhm.
About 10% of those can show an x-ray because of the calcium.
Okay, interesting. One more.
And finally, brown pigment stones. These are more about bile not flowing well, stasis, and infection. Often bacteria like E. coli are involved.
Wow, okay. Quite the collection. So moving on, who typically gets this? What are the main risk factors for acute cholecystitis?
Well, the biggest one by far is already having gallstones, or that biliary sludge we mentioned. That accounts for like 95% of cases.
So almost everyone with acute cholecystitis has stones first.
Pretty much. For the small group without stones, it's often people who are already quite ill, maybe hospitalized for trauma or another biliary issue.
And are there patterns in who gets stones in the first place?
Yes, definitely. It's more common in women. Risk goes up with age. Obesity is a big factor.
The bold 4Fs mnemonic.
Exactly. Female, 40, fat, fertile. It's a bit simplistic and maybe not entirely PC these days, but it does capture some key associations, though it can happen at other ages too, of course.
Sure. Any other factors?
Yep. Things like losing weight very quickly, pregnancy hormones play a role there, conditions like Crohn's disease, and high cholesterol or lipids, hyperlipidemia.
Okay, that gives us a good picture of who's at risk. Now let's get into the how. How does that blocked duct actually cause the inflammation, the pathophysiology?
Right. So imagine that gallstone blocking the cystic duct. Bile can't get out. Pressure starts building up inside the gallbladder.
Like a balloon filling up?
Sort of, yeah.
Yep.
And that pressure, plus the irritation from the stone itself, kicks off inflammation in the gallbladder wall. The wall gets inflamed, it swells, it gets distended.
Extended, right?
And the stretching and inflammation can actually squeeze the tiny blood vessels supplying the gallbladder wall.
Oh, so it cuts off its own blood supply.
It can do, yeah, leading to ischemia.
Yeah.
And if that whole process isn't stopped,
Uh.
well, things can get nasty.
How nasty?
You could get necrosis, where the tissue actually dies, or
Right.
perforation, a hole bursts through the wall,
Yeah.
or even an abscess forming, a pocket of pus.
Okay, definitely sounds like something you need to sort out quickly. So someone comes in with that classic RUQ pain. What else might be going on? What are the main differential diagnoses?
That's super important. The biggest one to distinguish is biliary colic.
How's that different? Also gallstones, right?
Yes, but biliary colic is just the pain from the stone moving or temporarily blocking things, without the significant inflammation of cholecystitis. The pain often comes and goes, maybe lasts a few hours, then settles. Cholecystitis pain tends to be more constant.
Okay, colic versus inflammation. What else?
Well, you've got to think about the liver, acute hepatitis.
Yeah.
Stomach or duodenum issues, peptic ulcer disease.
Okay.
The pancreatitis.
Right.
Even just a bad stomach bug, gastroenteritis, can sometimes cause upper abdominal pain. And for vaguer discomfort, things like reflux, IBS, maybe even rarer things like tumors need considering.
So lots of possibilities. It's not always straightforward.
Definitely not. Symptoms can overlap quite a bit,
Hmm.
which makes a careful assessment really key.
Makes sense. How common is this condition then? What's the epidemiology like in the UK?
It's very common. As we said, more common in women, and it gets more frequent as people get older.
And obviously more common if you already have gallstones.
Exactly. Figures vary, but something like 2 to 4% of people with asymptomatic stones they don't know about, develop symptoms each year.
And when they do get symptoms, what's most likely?
Biliary colic is the most common first presentation, maybe just over half the cases. Acute cholecystitis is next, maybe around a third or so.
And how many people actually get gallstones overall?
It's estimated around 10–15% of adults will develop them at some point. And just to give an idea of the impact, one study found over 25,000 emergency admissions for acute gallbladder problems in the UK over just a couple of years.
Wow, okay. That's a significant number. So let's focus on the presentation. What are the absolute key clinical features, the signs and symptoms that scream acute cholecystitis?
The absolute hallmark is severe pain in the right upper quadrant, the RUQ.
Describe the pain a bit more.
It's usually pretty constant, not colicky, coming and going pain. It can last for hours, often more than 6, sometimes up to 24 hours. Often bad enough they need strong painkillers.
Okay. And other symptoms.
Often feel generally unwell, fever, maybe chills, nausea is common, vomiting too.
And what would you find examining them?
Tenderness when you press on that RUQ area. Sometimes guarding where their abdominal muscles tense up to protect the area.
And then there's the classic sign.
Murphy's sign, yes. Very important.
Remind us how that works again. It's a key one for exams.
Absolutely. So you place your hand gently but firmly on the RUQ, sort of hooking your fingers under the ribs where the gallbladder sits. Then you ask the patient to take a deep breath in.
In.
If they suddenly catch their breath or wince in sharp pain as the diaphragm pushes the inflamed gallbladder down onto your fingers, that's a positive Murphy sign. It stops them mid-inspiration.
Got it. A sharp intake of breath stopped by pain.
Exactly. So, piecing it together, history maybe of some gallstone-type pains before, now constant RUQ pain, fever or raised inflammatory markers in the blood, and that positive Murphy sign, that combination is highly suggestive of acute cholecystitis.
Perfect. So you suspect it based on the clinical picture. What tests do you order to confirm? What are the investigations?
You'd start with blood tests, looking at liver function tests, LFTs, and inflammatory markers.
What do you expect to see?
Often the white blood cell count is up on the full blood count, showing inflammation or infection. LFTs might be mildly abnormal, maybe a slight rise in bilirubin or alkaline phosphatase, but often they're not drastically deranged unless there's a complication like a stone in the main bile duct.
Okay. Bloods first, then imaging.
Yes, the main imaging test is an abdominal ultrasound. It's really good, like 90–95% sensitive for seeing gallstones.
And can it see the inflammation itself?
It can show signs suggestive of it, yeah. Things like a thickened gallbladder wall, maybe some fluid collected around the gallbladder that's called perforation fluid. Sometimes even air in the wall if things are getting really bad.
So ultrasound is usually enough.
Often, yes. But if the ultrasound isn't clear, or maybe you suspect a stone has escaped into the main bile duct, you might need more advanced imaging.
Like what?
A HED scan is one option. It uses a tracer to see if bile is actually flowing out of the gallbladder. If the cystic duct is blocked, the gallbladder won't light up. Or an MRCP.
That's an MRI scan.
Yeah, magnetic resonance cholangiopancreatography. It gives really detailed pictures of the bile ducts and gallbladder without needing any contrast or radiation like CT. Very good for seeing stones in the ducts.
Any other tests sometimes needed?
You might do basic things like a urine test, chest x-ray, ECG, just to rule out other causes of pain, especially in older patients. And if you strongly suspect a stone in the common bile duct that needs removing, you might move to an ERCP.
ERCP, that's the one with the camera down the fruit.
That's the one. Endoscopic retrograde cholangiopancreatography. It can see the ducts and often remove stones at the same time. A CT scan might be used if ERCP isn't possible or fails, or if you suspect complications like perforation.
Okay, comprehensive workup. So you've confirmed the diagnosis. How do you actually treat acute cholecystitis? What's the management plan?
Right. The initial steps are supportive. Make the patient comfortable. So pain relief, often strong stuff like opioids initially. Antibiotics are usually given because infection is often involved or a risk.
And food.
Nil by mouth. Keep them MPO. You want to rest the gallbladder, stop it trying to contract. And IV fluids to keep them hydrated.
That's the initial bit. What's the definitive treatment?
The definitive treatment is nearly always surgery to remove the gallbladder. A cholecystectomy.
How quickly does that need to happen?
Ideally, pretty quickly. The evidence suggests Early surgery within the same hospital admission leads to better outcomes. For severe cases, the aim is often within 72 hours. For less severe ones, maybe within a week or so, but still during that initial stay if possible.
And what if someone is too unwell for surgery straight away or there's a delay?
Good question. If surgery isn't immediately possible, an alternative is percutaneous cholecystostomy.
Which
It's basically putting a drainage tube directly into the gallbladder through the skin, guided by ultrasound or CT. It lets the infected bile out, decompresses the gallbladder, and cools things down. It buys time, or can sometimes be a longer-term solution for very frail patients.
I see. And the surgery itself, is it usually keyhole?
Yes, the standard approach nowadays is laparoscopic cholecystectomy, keyhole surgery. Less pain, faster recovery than the old open operations.
Is open surgery still done?
Sometimes. If the inflammation is really bad, or there's lots of scarring from previous problems, or if there are complications during the keyhole procedure, they might need to convert to an open operation.
Are there big risks with this surgery?
All surgery has risks, but serious complications are uncommon. The most feared one is injuring the main bile duct, which happens in maybe 0.3 to 0.5% of laparoscopic cases.
Okay.
Other potential issues can include bleeding, infection, or longer-term things like post-cholecystectomy syndrome, ongoing tummy symptoms, or sometimes mild issues digesting fatty foods, though that's usually manageable.
What about people who just have gallstones but no symptoms? The silent stones.
Generally, the advice is watchful waiting. Don't operate unless they cause problems. The risk of developing symptoms is relatively low each year.
Unless.
Well, sometimes in younger patients, or those with specific risk factors for complications or gallbladder cancer down the line, surgery might be considered even without symptoms, but that's more nuanced.
And what if stones are found in the main common bile duct as well?
That complicates things a bit. Usually you need to get those stones out too. That might involve an ERCP before or after the gallbladder surgery, or sometimes the surgeon can explore the bile duct and remove the stones doing the cholecystectomy itself.
Okay. Seems like there are options depending on the exact situation.
Definitely. Management needs tailoring, especially when you get into complications like cholangitis infection in the ducts, or empyema pus in the gallbladder, or gallstone ileus, where a stone blocks the bowel. Those all need urgent attention, usually involving antibiotics, draining infection, and then dealing with the underlying stone problem.
Right. So, assuming treatment goes well, what's the typical outlook? What's the prognosis?
For acute cholecystitis treated promptly, the prognosis is generally very good. Getting the gallbladder out usually resolves the symptoms completely and prevents recurrence.
Any long-term issues usually?
Most people do really well.
Yeah.
Complications from the surgery itself are low risk, as we said. Some people might have minor digestive changes initially, but usually adapt fine.
Is there anything people can do to prevent it in the first place, besides managing weight?
Well, preventing gallstones is the key. While things like a healthy diet and exercise are good for overall health, the direct evidence linking specific diets to preventing gallstones isn't super strong. There's a medication, ursodeoxycholic acid, that can dissolve small cholesterol stones sometimes, but it's not really used for general prevention.
Okay. So, mostly about treating it effectively when it happens. Lastly, just to reiterate the dangers, what are the main complications if acute cholecystitis isn't treated properly or quickly enough?
Yeah, it's important to remember things can go wrong. The gallbladder wall can die off, that's gangrene or necrosis. It can perforate, spilling bile and pus into the abdomen, causing peritonitis.
Which is very serious.
Very serious. You can get an abscess forming next to the gallbladder. The infection can spread into the bloodstream, causing sepsis. Or a stone can block the main bile duct, causing jaundice and potentially severe duct infection, cholangitis.
Definitely not something to ignore. Okay, let's try and wrap that up. Acute cholecystitis, inflamed gallbladder, usually due to a blocked cystic duct from a gallstone. Key features are that constant RUQ pain, fever, and a positive Murphy sign.
That's the core of it. And diagnosis relies heavily on ultrasound, with treatment typically being supportive care followed by prompt gallbladder removal, cholecystectomy.
Excellent summary, and maybe a final thought for our listeners.
Well, given the gallstones are central to this, it does make you wonder, doesn't it? Even if we don't have strong proof for specific preventative diets, what subtle things about our lifestyle or internal workings might be contributing to forming these stones in the first place? It kind of highlights how interconnected things are in the body.
Definitely something to ponder. If this deep dive has been useful for your revision or just your understanding, remember there are loads more resources over at passmsra.com.
and also at freemsra.com for free tools and questions.
Great stuff. Thanks for joining us on the Deep Dive.